So I did attempt to summarize the yesterday morning's discussion about randomization. These represent my attempts to summarize, although I did get some input from some people on the panel, but I'll take responsibility for anything that's incomplete or incorrect. So beginning with the idea of why do we care about random assignment. When we talk about, the term I use is real-world randomized trials, but research on medical practice, standards of care, treatment. Some of the key differences between this and more traditional, what I would call sort of traditional clinical trials efficacy research, is that the true differences we are looking for are typically modest. The patient populations are quite heterogeneous. We're often just talking about complex causal pathways and competing effects of treatments, where both what we might consider to be benefits and risks or harms somehow get combined into some aggregate outcome. In these situations, random assignment to eliminate bias is especially critical because the effects are modest and the biases in observational studies are often insurmountable. So that leads to the question, does randomization in and of itself create or increase risk? And what the OHRP guidance actually states is that randomization should be treated as like one of many factors in research design that influence or possibly mitigate risk. Randomization influences the treatment people might receive, and the effect on risk is mediated through that change in treatment. The idea that randomization is somehow constrained subsequent treatment choice is actually not necessarily so, that constraints on treatment choice are study specific. Random assignment is not necessarily create or not create those subsequent constraints. And randomization could even mitigate risk because suboptimal treatment assignment may exist in nature and randomization may correct some biases. So the bottom line, does randomization increase risk, is it depends. We do need to consider there are other consequences of study participation, that participation in some kind of research may constrain treatment choices, providers may have other allegiances to the study protocol or to study progress rather than solely to the patient's interests, and there may be risks or burdens of non-therapeutic procedures, but these are consequences of study participation not specifically related to the random assignment of treatments. So when we say, does randomization increase risk, we have to say compared to what? And actually, if I had known, I would have included John Lantos's dramatic reading instead of this diagram here. But the ideal view is that we have in the state of nature personalized treatment, where treatment selection is systematic, guided only by evidence and by patients' preferences. And what we are juxtaposing that against is this research treatment, which is also systematic but selected randomly, with no allowance for patients' preferences. What we heard from Hal Sachs and from other people yesterday is that the state of nature really includes probably more haphazard treatment than systematic treatment, where treatment selection often happens for cryptic or hidden reasons. It may be guided by providers' habits or prejudices, by economic factors. And then what we heard from some speakers later is that many people unfortunately do not have standard of care. What they have is substandard treatment, where treatment is cryptically selected and often limited, especially to people who come from groups that are traditionally socially and economically disadvantaged. So the comparison is not so much this research random selection to this ideal world, but to the real world treatment that people are actually receiving. When we think about how randomization would alter treatment choice and subsequently alter risk, there were these two concepts that have even echoed in this morning's discussion. How would random assignment change the average expectation of benefits and harms? And this is really study specific. As we heard, there might be some comparisons where we would be able to make a fairly clear statement about change in average expectations and others where we would not. The change in individual experience, that random assignment would alter the experience of an individual, is pretty much a given. The difficulty is that the net effect of that, whether positive or negative for any individual, is often unpredictable. Going back to Rob's example of the headache and the toe pain, that's an example where, to put this in math nerd terms, we might be able to say that the between treatment variation is much greater than the within treatment variation, so that we might be able to have an a priori expectation of difference. In many of these cases where we're randomly assigning different standards of care, the within treatment variation is much larger than the between treatment variation. I think we are all clear that we need to communicate that difference in average expectation as part of some informed consent or informing process. I think we're a little less clear about the second type, both what we need to say about it and how we might say it. So this moves on to the communication challenges. It seemed to me there was a consensus that we need to come up with more comprehensible ways to describe this process of random assignment, because the ways we describe it now are often not very comprehensible. And this idea of more accurate descriptions of alternatives, that the current alternatives section in most consent forms mostly says, you don't have to join this study and you can get whatever treatment you want, although that might not necessarily be so for many people. But how do we describe to people what is the state of nature and what is the thing that might happen to them? I think we said there's clearly need for greater informed consent about usual care, but we have some work to do there. And then the final point, this idea of a therapeutic misconception, what we heard was that misconceptions about the nature of research are remarkably resilient, that even when we try to educate people about the random assignment process, there still may be a belief that my doctor can still choose what's best for me, but that the misconceptions regarding usual care treatment may be just as problematic, that the therapeutic misconception in everyday practice is different, but maybe just as important as it is in research. So I'll stop there, and maybe I should see if the other people who are part of this panel had anything they wanted to add to or correct about that.